arthroscopic giant needle rotator cuff repair is a translation of the golden standard open repair as described by Neer in the early 80s. The giant needle rotator cuff repair technique was developed in the early 90s in the GOC Shoulder Hospital in Bonn, Germany, and the first publication was in 1995. Most publications in the literature comparing the anchor double row technique to the transosseous repair have shown that the transosseous repair improve ultimate load to failure compared to a less load to cause failure in the double row anchor repair. The transosseous repair also restore the footprint, achieve the best pressure on the repair, and it has a stable fixation in cases of osteoporosis, while the double row repair has a gap formation between the tendon and the bone. There is a stress as anchor site, and the complications of anchor loosening in osteoporotic patients are high. The surgery is done with the patient in 80 degrees sitting position so that to have the acromion parallel to the floor, matching the X-ray. The arm is hanging freely for manipulations, and the gravity helps by pushing the needle through the bone from upward downwards. The instruments needed for surgery are mainly a strong needle holder, the arthroscopy hook, and sometimes we need the chop needle suture puller to pull the sutures through the tendon. The arthroscopy portals needed for surgery are the lateral posterior portal for the arthroscope, which is about 1 centimeter lateral to the acromion posterior corner. The posterior lateral portal about 1 centimeter medial to the acromion posterior corner. Two measuring needles are used to mark the medial anterior corner and the lateral anterior corner of the acromion, and in the same time are used to measure the space between the anterior acromion and the rotator cuff in order to monitor the subacromial decompression. The third portal, the lateral anterior portal, is done immediately above the head for instrumentation. In order to avoid shifting of the portal, it is made after filling the subacromial space with saline. After a study done in the 90s, we found that there is no impingement pathology when the space is more than 12 millimeters. I mean the space between the anterior acromion and the rotator cuff. So this is the standard for us for decompression. If the space is less than 12 millimeter, we do the decompression to get it more than 12 millimeter. If it is already more than 12 millimeter, then we don't do a decompression. And for that we use the measuring needles, in which there are markings every 5 millimeter. The first step done is by using a motorized shaver, a part of the subacromial bursa will be removed in order to visualize the subacromial space. After resection of the coracoacromial ligament from the anterior acromion, the periosteum of the lower surface of the acromion is removed with the motorized shaver. With a motorized acromionizer, a wedge resection of bone from the lower anterior acromial surface is made to increase the anterior acromion cuff space to be more than 12 millimeter. After the decompression, the space is 14 millimeter as measured by the measuring needle. After localization of the tear, the periosteum on the footprint area will be removed with a motorized shaver. After abrasion of the footprint area to get a bleeding surface, an awl is used to make holes for entry of the giant needle at the junction between the cartilaginous head and the footprint area. Now, after placing the anterior end of the 30 degrees arthroscope at the giant needle entry hole at the junction between the cartilaginous head and the footprint area, imagine a continuation of the scope on the skin as seen in yellow, and place the giant needle immediately through the skin anterior to the acromion as seen by the red arrow, in order to have the tip of the needle immediately anterior to the scope above the hole made by the awl in the bone. Here we see as the giant needle is passed through the skin anterior to the acromion, then through the torn tendon 1 centimeter medial to its edge, and pushed in the hole made before by the awl at the junction between the cartilaginous head and the footprint area. The arm is held with the left hand from the elbow, and the needle is pushed in the bone by rocking the arm in internal and external rotation. It is pushed straight down in 90 degrees angle to the head in a stepwise manner, centimeter wise, till it comes out through the skin laterally. Here we see the tip of the needle. It will be held with the needle holder and pulled out same as it was pushed in. Here we see a demonstration how the needle is pushed through the tendon, through the skin, and out through the bone in a stepwise manner. The two suture ends are held with a clamp, and the second giant needle is passed through the skin, through the bone, and pushed inside. By putting the needle in the tendon, and before putting the tip of the needle in the hole, the arm is slightly abducted in 30 degrees to avoid tension on the tendon with the needle by pulling it laterally. And then the needle is pushed through the bone. The second needle now is pushed through the bone in a stepwise manner as the first one, and the upper ends of the sutures are held with a clamp. Now the lower ends of the suture are pulled out through the instrumentation portal using a hook by passing the hook down in contact with the shaft to avoid soft tissue impaction. You will see the hook going down, and then we feel the sutures by having them under tension with the left hand, and then they are pulled out through the instrumentation portal. The lower ends of the sutures are held with a clamp, and the anterior suture upper end will be pulled out through the instrumentation portal. Here we go with the ring forceps through the portal and pull the suture immediately before it enters the rotator cuff. Now a giant knot is made. It is a sliding knot. Here we do 2 throws in one direction and another 2 throws in the opposite direction. The post will be held after that under tension. Before that, we put the loop in the hole in a concave knot pusher. Hold it with a clamp, and then the post will be passed through the hole, the second hole in the knot pusher, and by holding the post, the knot will be pushed inside the subacromial space, and that under tension of the post. And we see here, this is by pushing the knot inside, the 2 ends of the tendon come together and the tendon is fixed to the bone. In order to secure the knot, we pull the loop. Here you see it is now blocked by a quick pull on the loop. After that, we cut the rest of the suture, and the same thing will be done to the second suture. Here with the ring forceps, we will pull the upper end of the suture through the instrumentation portal, and here after putting 3 sutures in the repair and fixing the repair completely to the footprint area. After surgery, the arm is stabilized in arm brace in slight abduction cases, in case of a massive rotator cuff tear, or in an arm sling if the tear is small to medium. After surgery, the patient starts post-operative rehabilitation on the second day. The rehabilitation is done in 3 phases. The first phase is a passive assisted exercises with gentle stretching, which takes about 4 weeks to 6 weeks. The second stage is active assisted exercises with strengthening and gentle stretching, and the third phase will take place after 3 months with vigorous stretching and strengthening exercises using weights and strong rubber band. This is a case of a large massive rotator cuff tear. The patient was to have a reverse total replacement. He refused that, and we did an arthroscopic surgery. The head is completely uncovered. This after surgery, transosseous reconstruction of the rotator cuff. The patient, after 6 months from surgery, He is completely healed. The strength of the arm is normal, and the patient is a very famous orthopedic surgeon in Egypt. Here's another case with a massive rotator cuff tear without a biceps tendon before reconstruction of the repair. And we see how the infraspinatus is also completely torn, the supraspinatus, and part of the subscapularis. There's no biceps. And here, after reconstruction, of course, mobilization here is very important. It took a long time to get the mobilization of the remainder.